Favorable risk patients, we have, which we have quite a few, they can do extremely well with TKI monotherapy. In fact, I have several patients that have been on it for, greater than 5 years. So I think I do think there still remains a role for those agents for particular patients who have slow-growing disease and are favorable risk. And maybe those who are not wanting to have the potential added toxicity of combination regimens. So, but with that being said, I think the newer combinations certainly play a much bigger role in the intermediate and poor risk patients. However, they can also play a role in the favorable risk as well. And I think so. It kind of depends on a lot of factors, but one of the most important are the goals of the patient. Sometimes, we have perhaps, a younger, healthier patient who really wants to maybe push the limits of therapy and willing to take on added risk. And that will certainly treat them a lot differently than perhaps, an older patient whose goals might be slightly different. So, that's in general how we look at those, but trying to figure out who's going to be on maybe a double immune combination versus an immune and a VEGF, that's challenging. I think we're all trying to figure that out. There's some certain ways that I practice. I tend to favor more of a double immune in intermediate poor risk patients for a couple reasons. One is I do like to have a backup plan with the anti-VEGF therapies in the second line in case. And I do think the number of complete remissions that you see in the double immune combinations is a reasonable goal to shoot for in patients, and because I think if we can achieve a complete remission, that can lead to a durable response and potentially being off therapy.